Hello everyone and welcome to the screencast for adverse drug reactions for PM1C. I'm Catherine Langran and I'm one of the lecturers in pharmacy practice. So this screencast is split into two parts, and within those two parts we're going to look at what the term adverse drug reaction means and what the pharmacist's role is in managing adverse drug reactions. And this links into the learning that you'll be doing in your PM1B, PM1C workshops where you look at counselling patients on side effects of medicines, but it also looks at the pharmacovigilance, so reporting of adverse drug reactions and why that is important for patient safety and for learning and making further and future recommendations. So the first thing to think about is actually what an adverse drug reaction is, and I suppose a lot of you have heard perhaps about the term side effect. And the key difference here is that a side effect of a medicine can be beneficial or it can be adverse. So for example, if a patient had a significant rash that was really itchy at night and was keeping them awake, we might give them a sedating antihistamine. So the antihistamine itself is helping to treat the rash, but the fact that it is sedating is also helping the patient sleep at night, because it was otherwise they had a disturbed night's sleep. However, if you gave that sedating histamine in the morning and then the patient was very drowsy during the day, they couldn't drive, they couldn't do their normal work, for example, that would be an adverse effect. So the side effect of a medicine can be an adverse drug reaction, so something that we do not want to happen, or it could be beneficial. So this is the MHRA, the Medicines and Healthcare Regulatory Authority's definition of an adverse drug reaction. So an adverse drug reaction is something that is an unwanted or harmful effect of taking that medicine. So for example, we're giving a medicine to treat a patient's blood pressure, but an adverse drug reaction is the patient then developed diarrhea, for example. We do not want the patient to have that, and it's important that we manage those and we counsel the patient appropriately, and that the adverse drug reaction does not counterbalance the beneficial effect of that medicine for that patient. So adverse drug reactions can be separated into two types, type A and type B. Type A adverse drug reactions account for about 80% of the adverse drug reactions. For type A adverse drug reactions, they tend to be augmented to the pharmacology of that medicine. So for example, if you give a patient an anti-diabetic medicine, an adverse event of that is that actually their blood sugars can go too low. If you give a patient an anticoagulant, so something to stop having a blood clot, an adverse event of that is actually they might be at an increased risk of bleeding and bruising. So for type A types of reactions, the adverse drug reaction is predictable. You can predict it according to their pharmacology, and it is dose dependent. So the more you give of an anti-diabetic medicine, the lower the patient's blood sugars will go. And the way that you would manage this is that you would actually reduce the dose until the patient's blood sugars are appropriately controlled. So they're not too high, they're not too low. Okay. The more rare types of adverse drug reactions are the type B types of adverse drug reactions, which may be allergic or idiosyncratic, and by idiosyncratic means it's not known why they cause that adverse drug reaction. So things like patients who are allergic to penicillin, we can't predict who is allergic to penicillin or not. It's not necessarily a genetic thing. You're not necessarily allergic to penicillin if your parents are. Just some patients are allergic and some aren't. Okay, so it's not predictable. We don't know who is more what patients are more likely to have an allergic reaction or an idiosyncratic type B adverse drug reaction, and it is irrelevant on the dose. So if you are allergic to penicillin, for example, you would have that reaction regardless of whether they gave you 4 grams of penicillin or they give you 500 milligrams of penicillin. For this one, the actual morbidity is low, but the mortality, the likelihood that you might die from it, is actually quite high. And if that is the case, if you're experiencing a type B adverse drug reaction, the only option is to stop the drug, and you should not have that drug again. So adverse drug reactions, it's a really common thing to happen. Unfortunately, we give a medicine to treat one condition and actually the patient then experiences an adverse drug reaction, and that can cause perhaps sometimes more harm to that patient than good. And obviously if it causes harm to the patient, it might cause the patient to be admitted to hospital, which is then an increased cost to the NHS and potentially a risk that the patient may be so severe that the patient might die from that adverse drug reaction. So preventing harm caused by medicines is a really important role for pharmacists to undertake. So we know that adverse drug reactions can be very harmful for patients, but actually the good news is that most of adverse drug reactions can actually be avoided, and some of those can be avoided by actually thinking about interactions. So we talked earlier about anticoagulants, so drugs used to stop a patient having a blood clot, and it increases the patient's risk of bleeding or bruising. And one of those drugs is a medicine called warfarin, but warfarin interacts with lots of different medicines. So knowing that you're starting a new medicine with a drug that interacts and can cause this serious side effect, this serious adverse reaction, we can predict that there's going to be an interaction, and we can keep a very close eye on that patient. We can monitor them, we can adjust the dose of their medicines so that if the interaction is causing the adverse reaction, we can manage that. Thinking about contraindicated drugs, so sometimes in the BF it lists medicines either as contraindicated or to use it with caution. So if it says use with caution, it might be like use with caution in the elderly, which means you can still use that drug in the elderly. You just need to be very careful and keep a very close eye on that patient because they may be at more risk of adverse drug reactions. Or it might be this drug is contraindicated if the patient has renal impairment, which means that we shouldn't be using that drug in that patient, because if they have renal impairment and we use this drug, they're at a much higher risk of developing adverse drug reactions. And a key role for pharmacists is to do medicines use reviews, so to review patients' medicines, thinking where medicines can be stopped. Particularly sometimes patients get started on a medicine for, say they've had an ulcer, and then they continue taking this for a prolonged period of time, where maybe they really needed it for about 6 months or a year. The ulcer would then heal and then it can be stopped, but they might accidentally, the medicine's on their repeat prescription, they'll continue taking it for a prolonged period of time, and the longer that you're on a medicine, the more likely you are to develop side effects and interactions and other problems associated with that. So pharmacists have a key role in preventing, managing and reporting adverse drug reactions. We'll talk on the next slide about the patients who are most at risk of adverse drug reactions, and in those patients we want to be very cautious when we're starting or stopping any new medicines for that patient. There are certain drugs that when you see them on a prescription will potentially ring alarm bells or kind of red flags for you that this is a drug has quite serious side effects, things like methotrexate or lithium or warfarin, that whenever a patient is on them, we want to keep a very close eye on them. We might be doing regular blood tests, we might be doing regular checkups on that patient, maybe keeping an eye on their blood count or their blood pressure, or lots of different things to check that that medicine is safe for that patient to take. Within thinking about drugs causing adverse drug reactions, so within a class of medicines, some of them may be safer than others. So for example, when you give a patient a non-steroidal, so things like ibuprofen or diclofenac or naproxen, that can increase the patient's risk of having heart attacks and strokes, but some of them have a higher risk of causing the adverse drug reaction than others. So using the drugs in the class that have the lowest incidence of them, or changing it to a drug that doesn't cause that. So there's always some drugs that perhaps are safer than others that we might be able to try, and following guidelines and where the drug is first line, using that in the first instance for the patients. I mentioned earlier about the importance of a patient in doing regular reviews with patients, stopping anything that the patient doesn't need to be on anymore. Every time the patient brings in a new prescription, or you screen a prescription in a hospital, checking for interactions with their existing medicines, checking for interactions with anything new that's been started for them, and making sure that it's safe for the patient to take it. And this is where it links in with your PM1B and 1C, is that you counsel the patient. So if we know that that drug will cause a particular side effect or adverse reaction, we can tell the patient about it and tell them to be aware of it. And if it does happen, how they can either manage it at home, whether it's a short-term thing, it should kind of wear off within a few days, or whether it could be something they manage at home. So for example, opioid analgesics, so something like morphine, or codeine can cause the patient to be constipated, so making sure the patient has plenty of fluids, is drinking fibre, takes laxatives if they need, for example. Or if it's a very serious side effect, we need to make sure that we can report that adverse drug reaction so that we can learn more about what caused that adverse drug reaction, how often it happens, and how it might be prevented in the future. So there are certain patients who are more at risk of developing adverse drug reactions than others. So those at extremes of age, so the very old and the very young, are more susceptible to adverse drug reactions. In children, their systems for handling drugs are not really fully developed, obviously when they're a baby, and then as they grow they become fully functioning. And in the elderly, these systems, so their liver, their kidney, are actually kind of starting to slow down or potentially fail with age. Elderly patients are also more likely to have multiple or chronic diseases that will influence how the body handles or their likelihood of having an adverse drug reaction. Most of the studies looking at adverse drug reactions showed that females are actually at a higher risk of suffering from adverse drug reactions than males, and the reason for that is not known or unclear. Polypharmacy is where a patient takes at least 5 or more medicines, and where patients are taking 5 or more medicines, the likelihood that they will experience an adverse effect from one of those medicines increases by at least 50%. Patients that have concurrent diseases, so diseases that are happening more at the same time, so if the patient maybe has heart failure or renal failure or hepatic failure, all of those increases the risk of them having an adverse drug reaction. And generally patients who have a history of intolerance, so patients who maybe have already had an allergic reaction or a sensitivity reaction to a medicine, are more likely to then develop those to subsequent medicines that they have. So you may see patients, say on a hospital drug chart, and it has a list on the front of allergies, and patients may have several listed there because they are maybe hypersensitive or more likely to develop adverse drug reactions than other patients. So there was a study undertaken in 2004, and it was looking at why patients or patients who admitted to hospital with adverse drug reactions, which were the most common drugs that caused them. And they analysed over 18,000 patient hospital admission records, and they found that drugs that were most likely to cause admissions to hospital, the most likely was non-steroidal anti-inflammatory drugs, which can cause bleeding, they can cause cardiac events, they can cause renal problems. Patients also at risk of adverse drug reactions to the diuretic medicines, which can cause patients to have a low blood pressure. It can cause a disturbance of the patient's sodium or potassium. Patients can also become dehydrated. Warfarin, we've mentioned already, is an anticoagulant, so increases the patient's risk of bleeding or bruising. ACE inhibitors or angiotensin II receptor antagonists can cause acute kidney injury. ACE inhibitors are associated with patients developing a cough. Antidepressants and lithium can cause various cardiac effects and electrolyte disturbances. Beta blockers, so things like atenolol or bisoprolol, anything that ends in ol, can cause patients to have a slow heart rate. It can cause bronchospasms, so difficulty breathing. They can cause a low pulse for a patient. We've mentioned already about opioids, so things like morphine and codeine, that can cause respiratory depression. It can cause severe nausea and vomiting, constipation, confusion, hallucinations, things like that. Digoxin has a very predetermined adverse drug reaction thing, so particularly when patients have renal impairment, digoxin can cause visual disturbances. They can feel like kind of all their colours and the vision gets kind of very blurred and mixed up. They can feel very sick with it, very dizzy. Prednisolone, so patients that are on long-term steroids are at increased risk of being immunocompromised. They're increased risk of developing diabetes, glaucoma, changes in their blood sugars, changes in their blood pressure. And clopidogrel, it also affects the patient's blood clotting, so again increases the risk of a patient bleeding or bruising. So basic adverse drug reactions are listed in the BNF as side effects of those medicines. And the BNF and the summary product characteristics for the medicines will list all of the side effects that are clinically relevant that a patient may experience that we might need to manage. Generally, they're listed in the BNF by order of frequency. So those that are very common, that may happen in 1 in 10 people taking that medicine, may experience that side effect. To those that are very rare, which is more than 1 in 10,000 patients taking that, may experience this side effect. So typically, when you're counselling a patient, we would always let them know about the very common or the common side effects where 1 in 10 or 1 in 100 patients taking that might experience it. But also there may be some rare side effects that may only happen in 1 in 10,000, but if they happen, we need to do something about it. So, for example, if the patient had severe bleeding, for example, that may be a very rare side effect of that medicine, but it's serious and they have to report it to the doctor, and we have to stop that medicine and we have to manage that bleeding in appropriate ways. And typically the side effects in the BNF are listed by body systems. So it might be the adverse drug reactions related to the central nervous system, adverse drug reactions related to other body systems. And when you look in the BNF, you'll see how they're listed, and that will make more sense for you when you're using the BNF in your PM1B workshops. So this leads into what you might be doing in your upcoming PM1B and PM1C workshops. So in those workshops, you're going to be screening prescriptions and you're going to be dispensing prescriptions, and then you're going to be doing a consultation with a member of staff. So you may be counselling them on medicines, and part of that counselling is explaining to them about the side effects of those medicines. So the scenario that we're going to work through here is for doxycycline capsules. And what I want you to first of all think about is where you might find that information, and this is what we're going to talk through. Which of those side effects would you list and would you speak to the patient about, and which ones do we think are the most important? And we're going to work through this example together, and then hopefully you can apply it when you're in your PM1B, PM1C dispensing classes. So these are the key resources that you would have with you in those workshops. So you'd have the BNF, hopefully you'll be using the paper BNF in the workshops, but you also have access to the BNF online with Medicines Complete. You'd have the box of tablets in front of you, which would have a label on, and the label may have some counselling points on, some warning symptoms, for example, and inside the box you'll have the patient information leaflet, which contains a lot of information, and there's always a section in the patient information leaflet about side effects or adverse effects of this medicine. In addition to the BNF, the box and the patient information leaflet, you can also look up the summary of product characteristics, the SPC. This is a legal document which lists all the possible side effects of a medicine. So this can be found on the Electronic Medicines Compendium, and we encourage you to look this up and use this throughout your degree program. So emedicines.org.uk/EMC. However, in here it does list all of the possible side effects because it is a legal document, but it doesn't necessarily always give you an indication of which are the most common or which are the most serious. So thinking about here, there's a long list here, and it talks about hypersensitive reactions, infections, blood and lymphatic systems, endocrine systems, nervous systems, your eye, GI, your liver, your skin, musculoskeletal, renal and reproductive. So before we said it's listed by system, so this is a really lovely example of how this medicine has lots of side effects based on all the different systems that it's affected by possibly taking this drug. So that all that information that was in the summary of product characteristics is summarised within the BNF, and this is in the BNF the side effects for tetracyclines. So doxycycline is the name of the medicine, and then tetracyclines is the drug class that the doxycycline belongs to. So it says for any patient that's been prescribed doxycycline or a tetracycline, it's common, so 1 in 10 or 1 in 100 patients may experience angioedema. We'll talk on the next slide what that is. They may have diarrhea, they might experience a headache, they might have this skin reaction or hypersensitivity, they might feel sick, they might have inflammation, pericarditis, so inflammation of the heart, photosensitivity, so their skin becomes more sensitive to sunlight and skin reactions. And again, there's a systemic lupus, which again is another skin reaction and vomiting. So typically we would say to the patient, I would explain about the diarrhea, the headache, vomiting, nausea, and then potentially you might be at risk of any kind of skin reaction. And then if you do have that skin reaction, you should report that straight away to the doctor. There are some serious or rare side effects here, and these might be things that the patient, if they were feeling particularly unwell with it or admitted to hospital, they might do a blood count and they would be able to see, for example, if the patient had thrombocytopenia or anemia or eosinophilia. So the patient wouldn't be able to report those, so I probably wouldn't explain to the patient that they're at risk of those. Okay. So as mentioned on the previous slide, the side effects of doxycycline, if something's listed in the BNF, you're not sure what it is, it's always worth looking it up, finding out what it is, rather than just saying to the patient this increases your risk of angioedema. Well, what does that mean? So this picture in the top left here is of angioedema. So it's a swelling of the hands and feet, around the eyes, the lips, the tongue, and it's typically an allergic reaction. So if they do experience that, they need to stop taking that medicine and report it to the GP. The other picture at the top here is this HSP, so Henoch-Schönlein-Papier, which affects the blood vessels and causes a spotty rash. It's not normally serious. It quite often looks worse than it actually is, but if we don't manage it, it can potentially cause renal problems for the patient, and it's typically is on kind of the patient's legs, around their knees, around their ankles, or on their abdomen as well. Pericarditis quite often occurs after viral infections. Patients might present with severe chest pain or high temperature or fever. If they have any kind of sharp or stabbing pain in the chest, they need to contact the GP. So it's basically an inflammation of the pericardium which surrounds the heart. And it typically, when they lie down, the pain gets worse. So they need to contact the GP as soon as they experience that. And then systemic lupus erythematosus is an autoimmune disease. It affects the body's immune system, where the body mistakenly attacks the healthy tissue. It can affect the skin, the joints, your kidneys, and typically presents it as skin rashes, particularly on your nose and on your cheeks, joint pain, stiffness, extreme tiredness. So we've looked already in the BNF for the side effect for the class of medicines for all the tetracyclines. So just looking at doxycycline, it also says that doxycycline can cause dysopnea, which is difficulty or laboured breathing. It can cause hypertension, so a low blood pressure, peripheral edema, so accumulation of fluid for the patient, particularly around the lungs, and tachycardia, so an increased heart rate. Okay, it can also cause GI effects and colitis and other things. Perhaps are quite rare for that patient, but typically we would say to the patient it can cause breathing problems. It may make your blood pressure go low, so be careful if you feel dizzy, if you have any accumulation of fluid, or you feel kind of your heart racing, then do let the GP know about that with this medicine. And the final place that we would look at when we're doing this is actually the cautionary labels, and these will be, when you have the box in front of you, this will be printed on the label. So it will be printed not to take indigestion remedies with this medicine, because it affects the absorption of this medicine if you do take them at the same time. Take the medicine at regular intervals, and this spot here, label 11, protect your skin from sunlight, and that's to do with the hypersensitivity, the photosensitivity reaction. So if you go out into bright sunlight whilst taking this medicine, you're more likely to develop the sensitivity reaction, more likely to develop a rash, and have very kind of a sore skin or an effect according to that. And it's important that you swallow it whole with a full glass of water. So we're coming to the end of part 1 of this lecture, and I'm going to leave you now with 3 questions that I'd like you to think about, and take a break from the screencast, think about the answer to these 3 questions, and then we'll report back on those in the second part of this lecture recording. So these questions are related to medicines and how they undergo clinical trials before they come out to market. I'm thinking about how a medicine is used or tested in clinical trials influences how adverse reactions may be picked up in clinical trials. So before a new drug is marketed, how many patients do we think will have been treated with it? And thinking back how that may relate to the incidence of some of the side effects that happen in patients. Okay, so roughly how many patients do we think might be recruited into a clinical trial for a new medicine to be tested on before it is given its authorization and brought out to market? The second question thinks about, within those clinical trials, what type of patients do we normally have in a clinical trial? Do we have patients who are pregnant, who are children? Are they normal healthy individuals? Are they elderly? And are they patients with concurrent diseases? Okay, so in a typical clinical trial where they're testing a medicine to see whether it has an effect, see whether it has any adverse drug reactions, whether it's safe to market, what population are they testing it in? And as I'm sure you're aware, some of the clinical trials, particularly the early stages, are done on animals. So if you are undertaking a clinical trial where you're giving that medicine to an animal, so to a rat, for example, which of these types of adverse drug reactions could we see in the rats or the mouse that they are experimenting on, and which ones can we see and which ones can't we see, and why is that important when we're thinking about we're going to be using this in humans in a large population. Okay, so that's the end of part 1 on adverse drug reactions. So start thinking about the questions 1 to 3, so thinking about number of patients in clinical trials, types of patients in clinical trials, and types of reactions that we can or can't observe in animal trials. And then once you've reflected or had a guess at those 3 questions, then please start the part 2 recording and we'll go through the answers to that and about identifying and reporting adverse drug reactions. Thank you.